Next, we'll go on to Dr. Ronnie's talk, how to enhance trabeculectomy using antifibrotic agents.
Yeah. So thank you for the invitation. It's a pleasure to be here. And I think after they showed my presentation 2 times, it's not going to come back the third time. Yeah, so I'm essentially going to talk about these two things: creation, use of antimetabolites, and use of sutures. So basically, we don't want blebs which look like this, and that's very important because with the use of antimetabolites, this does happen. So you need to use it properly and safely. And Kiran has already alluded to this, that you can actually use mitomycin 0.2 or 0.4. Those are the two commonly used concentrations, or 5-FU, which you use undiluted at the same concentration. Duration varies from 1 to 3 minutes in both of these. Nowadays, the use of 5-FU at the time of the primary surgery has come down substantially, and we normally use only the mitomycin. It's important that when you reconstitute mitomycin, that you reconstitute, it comes in a 2 milligram per kg per ml, a 2 milligram powder. So you reconstitute with 5 ml of water for injection. It's important not to use BSS because that's not what's supposed to be used. And when you do this, you get about 0.4 milligram per ml. If this is what you want to use, you just use that solution from the bottle the same way. If you need 0.2, you take 1 ml of this, dilute it with 1 ml of water for injection, and use that. So the dilution is very important. Whenever you have a new theater nurse, you need to know, you need to actually train them. It makes sense to leave this written up in your OT so that there's no confusion. And then you put it in a little bowl like that. Those 3 sponges that you're using, then in this case 4 sponges that you have there, are soaked in mitomycin, and this is what you place under the conjunctiva. It's important that you do not take shortcuts on this. You do not decide to use something like cotton, because those little fibers, once they are soaked in mitomycin and left, they will not come out from under the conjunctiva, and they will stay there and cause problems. Whenever you're applying antimetabolites, you need to follow the large area treatment protocol that was described by Peng Ho, and this is basically to prevent the ring of steel from appearing. So when you treat a large enough area, just like Thomas was demonstrating, at the edge of the area that you have treated, you have partly treated cells, and that sets up an inflammatory reaction, resulting in a ring like that, which keeps pushing your bleb smaller, and you'll end up like with a bleb that looked like what I showed you in the first picture. So when you're it's all supposed to play automatically. So anyway, so whenever you're applying the mitomycin, this has already been demonstrated, but here you just, what I want to show you is we're using 3 sponges, and we're trying to push them as far back and treat as large an area as possible. So this is the supranasal quadrant, but you can see that the sponges are occupying a fairly large area there. And once you have done this, don't forget to take off the sponges and do a sponge count. This is really, really important. You should know how many sponges went in, and you should know that the same number come out. And that's absolutely essential whenever you're using an antimetabolite. And once you have got the sponges out, the forceps that you use to handle the sponge and the bowl of mitomycin goes off the trolley immediately, so that even by mistake, you do not use these instruments on the eye again. So if you want to avoid these localized thin cystic blebs, it's important that you wash the mitomycin. I'm not going to show this video. There's nothing much there. And it's also important to talk. So we'll now come to the next step, which is suturing the incision. So when you're suturing, obviously you're going to suture the flap. And when you suture the flap, the 2 questions that come up very commonly is, does the size of the flap matter? The size of the flap doesn't matter from a filtration point of view. Does the shape matter? Shape also doesn't matter from a filtration point of view. What matters is the overlap. That is, what is the distance between the edge of the ostium and the edge of the flap. So if you have very little overlap, you'll need to put a tighter suture there. If you have very huge overlap, you can actually manage with a looser suture. And this is the only thing which really matters. You try and direct the flow posteriorly. You try and dissect anterior nuclear cornea. This Kiran has already covered. And see, look at the position of the sutures. Now, if your sutures are sort of in the middle of the flap, then you're going to have flow anterior to it, which is going to result in a slightly anterior bleb. If you keep your sutures closer to the base of the flap, your flow is directed posteriorly, and this is what you should try and achieve, so that you'll end up with a posterior bleb, which does not cause you issues. The flap closure, you need to titrate the tightness, you need to titrate the flow, and you need to be able to do something with it post-op, which is why it's best to use releasable sutures. you need to mark the critical suture. The critical suture is when you're doing the suturing, where did it flow from the most? Was it the nasal side or the temporal side? Or if you prefer to put a fixed suture nasally, was it the superior side? So you mark that as a critical suture because you know that whenever you're taking that suture off, you're most likely to have more of flow. So if you're taking it off very early post-surgery, you may not want to take off the critical suture. You may want to wait for that. And the other thing you need to make sure is once you have sutured, you have no overfiltration on the table. It's much easier to deal with a high IOP than a low IOP post-glaucoma surgery. So whenever you're taking the releasable injury suture, there are a few things. One is the limbal entry should be through the cornea and not subconjunctival, because if it's subconjunctival, it acts like a wick. You should trim or bury the edge to avoid a windshield wiper syndrome, and you should use multiple releasable in high-risk eyes. So basically what you're doing here is, what I'm going to, can you play this? Okay. So what I'm showing you over here is the dotted portion is the intracorneal portion of the suture. So you're taking that intracorneally. The only reason to take this intracorneally so it doesn't hang around there and irritate the surface of the eye. Now this part is important. When you're crossing the limbus, you should be intrastromal in the cornea. You should not be subconjunctival. Then you come out partial thickness through the flap, and you take another partial thickness pipe through the sclera, then onto the bed on the other side, and you take a slip knot. Basically, you can take 3 throws or 4 throws. Less than that, you are not going to get a slip knot, but at least 3 throws. And you cut the loose end. So that's all that there is to it. What I can you play the video, please? What I've tended to do now is I have extended this buried portion. I come in reverse from the sclera. This is what you're seeing there. And I leave a very, very small corneal loop. And the rest of the suture is similar. So what happens there is you don't have that little edge either. And with this reverse, that get epithelialized very, very easily. And you don't even need to bother about taking it off later if it is epithelialized. So when you want to titrate the intraocular pressure, basically what you're doing with your sutures post-op, usually it's best if you do it within 3 weeks of surgery. It may be a little more effective with antimetabolites. You may be able to push it a little bit longer. But whenever you release or do anything to the suture, do it one suture at a time. Do not massage immediately after release, and assess your IOP and bleb and AC depth an hour later. So play this video, please. So basically, this is somebody who's already had a bleb. This is post-op, and you can see that I've got the patient on the slit lamp. The patient is looking down, and I'm trying to massage, and nothing much is happening. So this is a classic situation in which you would decide to do something to that suture. So here you have 2 options. You can either remove a releasable, which unfortunately neither of these videos is working, which basically means you just need to pull that suture and take it off, or you can use an argon laser suture lysis where you use an argon suture to tamponade the suture and just use a laser to cut it. Both are fairly effective, and if done properly, this is pre and post release. You can see that a small little scarred bleb. Post argon laser suture lysis, you're seeing a fairly large diffuse bleb which goes around. So if you have done it as a correct time, you can probably get a fairly good result. Don't forget that if you're very aggressive with this, you might sometimes end up with a shallow anterior chamber even there. So when you want to maximize your surgical outcomes, the use of antimetabolites and the use of releasables are critical to this, because one helps with the healing, the other helps with the titration of flow. And both are critical steps in trabeculectomy surgery, as with everything else. Thank you.